In this video, we will discuss about beta blocker on ischemic heart disease. The most common cause of ischemic heart disease is arteriosclerosis block on coronary artery. It blocks the blood supply to certain heart tissue area. The symptom of ischemic heart disease, such as chest pain or angina, occurs when there is an imbalance between oxygen demand and supply in the heart tissue. Usually, the heart can adapt its blood supply to its own needs by vasodilatation or autoregulation, unless the vessel walls are damaged or cannot relax. The reduced blood supply may be due to partial obstruction by atherosclerosis or spasm in the coronary arteries. When the supply and demand for oxygen are marginally balanced, an increase in cardiac demand with any physical or emotional exertion can cause a relative deficit of oxygen to the myocardium. Basically, treatment for ischemic heart disease can be divided into two ways. First, increase the oxygen supply by dilating the coronary artery or prevent further occlusion of coronary artery. For example, nitrate, aspirin, or clopidogrel. Second, reduce the oxygen demand by decrease the heart activity. For example, by taking rest or giving beta blocker, which is the highlight of this discussion. Beta blockers are first-line therapy in the control of symptoms in patients with chronic stable angina, particularly avert-induced angina. Beta blockers act by antagonizing the physiologic effects of catecholamines, norepinephrine and epinephrine, on beta receptors. There are three distinct types of beta receptors. The first is beta-1, which are found primarily in heart muscle. Activation of these receptors results in increases in heart rate, contractility, and atrioventricular conduction, and a decrease in AV node refractoriness. The second one is beta-2, which are present in heart muscle but are more prominent in bronchial and peripheral vascular smooth muscle. Activation of these receptors result in vasodilatation and bronchodilation. The third receptor is beta-3, which are found in adipose tissue and the heart. Activation of these receptors may mediate catecholamine-induced thermogenesis and may reduce cardiac contractility. Beta blocker effects on ischemic are mediated by a reduction in myocardial oxygen demand. Myocardial oxygen demand varies directly with heart rate, contractility, and left ventricular wall stress, or antihypertensive action, each of which is diminished by beta blockade. The decline in heart rate is determined both by the degree to which the heart rate is sympathetically activated, as with exercise or stress, and to the properties of the beta blockers, which are cardioselectivity, intrinsic sympathomimetic activity, and alpha-adrenergic blocking activity. The first is cardioselectivity. Cardioselectivity refers to the ability of a drug to preferentially block the beta-1 receptors. Non-selective beta blockers have equal affinity for the beta-1 and beta-2 receptors, while cardioselective agents will primarily inhibit the beta-1 receptors. Cardioselectivity is a relative property, and substantial beta-2 receptor blockade can also occur at the higher doses that are often required to treat angina. Intrinsic sympathomimetic activity, or ISA, is the second property of beta blocker. Intrinsic sympathomimetic activity, also called partial agonist activity, providing low-grade beta stimulation at rest, but acting as typical beta blockers when sympathetic activity is high. Some beta blockers, such as pindolol and acebutolol, have intrinsic sympathomimetic activity, or ISA. Alpha-adrenergic blocking activity. It blocks both beta and alpha receptors. As a result, they reduce peripheral and coronary vascular resistance. They are both non-selective beta blockers without ISA. Until now, there are three generations of beta blockers. First generation is non-selective and no vasodilatation. In this group, we have propanolol, timolol, pindolol, sotalol, and nadolol. Second generation is divided into two groups. First, beta-1 selective without vasodilatation. In this group, we have atenolol, metoprolol, and bisoprolol. The second is beta-1 selective with vasodilatation. In this group, we have nebivolol and acebutolol. The third generation of beta blockers is also divided into two groups. First, non-selective without vasodilatation. In this group, we have carvedilol and labetalol. The second one is selective beta blocker. In this group, we have betaxolol. That's all our discussion about beta blocker for ischemic heart disease. If you have any question, please don't hesitate to ask the question. Thank you.